Welcome, everyone, and thank you again for joining us this afternoon. My name is Rachel Smythe, and I'm the Education Coordinator here at the Caregiver Resource Center OC. Since 1988, the Caregiver Resource Center OC has been a trusted partner for Orange County families who are coping with the physical, emotional, and financial responsibilities of caregiving. By providing families with individualized supportive services, the Caregiver Resource Center stands apart as the only Orange County agency that focuses exclusively on the needs of caregivers who are coping with a loved one who has a chronic illness. And the Caregiver Resource Center provides family consultation, support groups, assessment and care planning, counseling, respite planning, and community education. And here at the Caregiver Resource Center, we host a live stream each month, and you've joined us this afternoon for What is Hospice? And so today I'm joined by Jackie Yeverino, who holds a master's degree in business administration and serves as the Chief Growth Officer for Parentis Health. And we've been joined by Jackie before, so we're glad she's back with us. So thank you so much for joining us, Jackie. And I'd like to give you the chance to introduce yourself before we jump in. And if you've joined us on YouTube or on Facebook and you're watching in the audience, please feel free to share comments or ask questions throughout the live stream. And with that, Jackie, if you wouldn't mind introducing yourself, your role, and the name of your agency.
Sure. Well, thank you for having me again, Rachel. My name is Jackie Yeverino, and I'm the Chief Growth Officer with Parentis Health here in Orange County.
Wonderful. Thank you for joining us again, Jackie. We appreciate it. And you always have such good information. And so we're always happy when you're able to join us. So today we're talking all about hospice care. So there's a lot of myths, misunderstandings, and so I'm really glad that you're here to help clear up some of those questions that many families have, that I myself have had before I had a better understanding. So enough from me. So what would you say, what is hospice care?
So hospice care is available to all people that have a life expectancy of 6 months or less. And truly, this is my passion. I've been in hospice since 2007, and I know that there are so many myths around hospice and what hospice does, what they don't do. But really, truly, it focuses on the patient's physical, emotional, social, spiritual needs, rather than actually trying to cure their illness. So they definitely have to have a life expectancy of 6 months or less.
Okay. And so you mentioned a few different components of what hospice entails, spiritual care, medical care, all these different things. And so could you go a little bit more in depth about what types of services are included with hospice care?
Sure. And I think the best way to speak to that is I always talk about the circle of care, where the patient and the family are in the center and the hospice team is around the patient and the family. So you have the physician, so they can actually keep their attending physician if the attending physician would like to stay and provide services. If not, our physician is available and will make visits as well. Then there's the RN who really oversees the care. So that's the nurse case manager. So the RN provides pain relief, nursing care, and things of that nature. Then you have the master's level social worker, and truly the social worker provides that psychosocial support, but it's so much more than that of being part of the team. It could really help the family during this transition of possibly helping with arrangements. A lot of times families are not thinking about that. So those are things that the social worker can really initiate. Maybe it's helping them with caregiving and other aspects that the family just hasn't had the time to do because they've been dealing with, a family member that is, dying and has a life-limiting illness. Then there's also the durable medical equipment that's provided and help with everyday tasks. So hospice is not there 24/7. However, there is a schedule for the family, so they know when the nurse is coming in. So his visits could be 1 to 2 times a week. Then there's what's called a certified home health aide who really comes in and really sees that patient and touches that patient, meaning whether the patient can still take a shower or actually do a bed bath. And typically those home health aides truly see a lot. They see skin breakdown, they see wounds and things that are happening with the patient. So that's why it's really important to have that team approach. And they come in and do the bathing maybe 2 to 3 times a week. And again, the other components, as far as the social worker, the spiritual counselor, which they're non-denominational, and bereavement, are truly there to support the team and support the families. A lot of times, some families have their own beliefs and don't want those components of hospice, but just knowing that they're there, we even coordinate, let's say, last rites with the diocese. So we find out all that information first from the family as to what their background is so that we can really customize their care plan. So it's really, really providing that clinical component, the psychosocial component, and the spiritual component.
Wow, it's so incredible. And like you called
Really.
it, is that circle of care. And so just to have the patient and their family surrounded by all of that care and compassion is, I think, very powerful. And you kind of alluded to it, but so it sounds like, I mean, between a nurse coming 1 to 2 times a week, home health aide 2 or 3 times a week, that's quite a bit of support. And so I was just wondering about how many times per week will a family have somebody coming in and checking in on them?
That's a great question. So our the goal really is for that nurse case manager to at least be able, and sometimes the visits can vary. It could be an hour, typically for the nurse. For the home health aide, a little bit longer. It could be an hour and a half, depending on the patient, depending on the type of bath. I would say that we can actually set it up, especially if we know that there is immediate decline, for the patient to really be touched every day. And when I say that, it could be that, as I mentioned, you have a set schedule for the home health aides, which could be up to 3 times a week, and then the nurse up to 2 times a week. But then a lot of times in between, we'll have coordinated visits with the social worker and the spiritual counselor. So they truly are getting someone, whether it's on the phone, and sometimes they decide, okay, there's too many people in the house. Maybe we can just talk over the phone. And that's okay as well. That's why we ask them all these questions, and it's a customized care plan for them. Some families, we become their family, right? And so it truly depends on how much they want us there, but we really make it a point for them to know what the schedule looks like every week so that they know what to expect, and so that they can really make sure that they're there, or that the caregiver's there if they have one as well.
That's very helpful, because I know sometimes with home health even, or hospice or palliative care, I know sometimes there's not as much of a set schedule, and so that can be a little bit challenging for families. So that's nice to hear what you just shared.
And again, I feel that, and it is confusing sometimes, because I think for families, they are wanting us to be there more, right? Um, the reality is that we're available. So 5 o'clock hits, it goes right into triage, and they'll have that team, that consistent team, throughout the week and even after hours, because typically the triage team is the same team that they're working with, when they call, they speak to someone that they know them by name, and they already are like, I'm not feeling well, can you please send someone? It could be 3 in the morning, it could be 3 in the afternoon. There's not a set time, and that's the beauty of hospice, is that it truly is really geared for the patient and family and their decline.
That's great. And I know you mentioned, if somebody has a life-limiting illness, typically about 6 months remaining of life, what would be some of the reasons, or maybe some of the most common diagnoses that someone's receiving hospice? What is it that you see most often when it comes to hospice patients?
So we are definitely seeing, you've got obviously the cancer diagnoses, different types of cancer, lung cancer, breast cancer with metastasis, but we definitely are seeing a lot of dementia. And truly, there's not, the diagnosis per standard can't just be dementia, right? For us in hospice, it has to actually be very specific. So Alzheimer's dementia, vascular dementia. So we definitely are seeing a lot of that, which in diagnosis terms, it could be senile degeneration of the brain. And we definitely do see a lot of COPD, which is, and then congestive heart failure as well, CHF. So those are, when we talk about the frequent flyers as well in the hospital, that's what really the ER department, that's what they're seeing. They're seeing, the exacerbation of, congestive heart failure and COPD, and it's typically seeing them coming in and out of the hospital as well. So those are ones that we definitely are seeing more as far as hospice diagnoses. There are other diagnoses, but that's what we are seeing definitely more of. And sadly, with dementia, we're definitely seeing an increase in that as well.
Right. And I'm glad you brought that up, that you mentioned that, because here at Caregiver Resource Center, we have a lot of family caregivers whose loved one has dementia or a different type of cognitive issue. And even as they're, towards the end of their life, they have the misunderstanding that they believe that they don't qualify because they don't have a different illness. So I'm glad that you brought that up, and it sounds like it's worth exploring for somebody whose loved one has dementia, or if they themselves do, to at least call and see if this would be a good fit, depending on what their goals of care are.
That's a very good point. I do feel that so many, because dementia, we have a lot that actually what we call they graduate off of hospice. And typically it's the dementia diagnosis, because they're getting all this care with hospice, and then all of a sudden they're maybe eating a little bit more, or they're gaining weight. And so they may come off of hospice. They definitely will come back on because they definitely have dementia. But end stage, there are definitely criteria to look for. And I think that it can't hurt to be able to ask your physician, can we do a hospice evaluation, just so that the hospice agency can get what we call a baseline as to where they are, right? Because have they had, so many things, infections, have they had frequent UTIs? That's always a big one. It takes a village, right? A lot of times I'll ask families, I'm like, you know what, you're right. She was eating 3 meals a day. Now she's eating 1. Now she's pocketing food, and I'm noticing that, she's aspirating. All these things because the families are the historians. They typically will tell you these are the things that are happening. But what's happened was, when you're so enveloped as a caregiver, you may not see those aspects. And so that's why having other people around to be able to say, you know what, let's really look at it. Maybe let's do some blood work and see what's going on with your loved one. So I definitely think it's something to look at as well.
Thank you, Jackie. And so kind of along those lines, so how would somebody get connected with hospice? Do they call you up directly? Do they go to their doctor? What is the hospice referral process like?
I always want and I always educate families that it is their choice to ask their primary physician for what's called a hospice evaluation order. And if they're working with an agency, then they can send it directly to the hospice agency. But I feel that also empowers the family for them to know that they are the advocate. And it's okay to say, you know what, something's going on with my loved one. I truly don't know. I've had them here. And usually physicians will say, yeah, I look at your records. You've been here several times in the last, let's say, couple of months, or you've been calling into the office a lot. Maybe something is going on. And so for that primary physician, it's basically an order, just like they write on their pad. It's a hospice evaluation and admit if eligible order. And that starts the process for the hospice agency. Typically what we ask for is a lot, some lab work if there has been some, or an H&P, like their history and physical, because that gives us a good look back as to what's been going on with the patient, so that we can, and we do involve the primary physician if they, as much as they want to stay involved. A lot of physicians actually do stay on as attending, but a lot of them don't because they may not want the phone calls after hours. And so then our physician will take over, but then we still give them updates so that they know what's going on with their patient as well.
Oh, that's so great that there's still that connection. And I'm wondering too, so what does the timeline look like between when, let's say somebody does ask for, and I'm writing down all this terminology so that I have these phrases I can refer to as well. So correct me if I'm wrong here. But so once somebody's requested a hospice evaluation order and they get that, and if they get the admit if eligible order, and let's say then your team receives that, how quickly do services start? Is it hours? Is it days? Is it weeks? What does that look like between when you get that referral and when services begin?
That's a great question. So from the time like that we get the actual, all the paperwork, and what I always like to say is I want to paint the picture for the admission nurse, because the admission nurse will get the paperwork. Yes, they are placing eyes on the patient. But the goal is to be able to have as much information. I call it really the history of the patient from the doctor's office. And so once we have that, it's hours. Sometimes from the time that we get the information, within less than 15 minutes, we have our director of nursing reviewing the history and physical. And then within that hour, we're already scheduling with the family to send out the admission nurse. The admission nurse is the one who typically does the admission to hospice if the patient is eligible. And then the next day, the actual patient will meet their actual RN case manager, who will be the nurse moving forward. And I always tell the families that when we're speaking on the phone, and kind of really the admissions coordinator is walking them through this process. It's a process. And I always tell them, right here, right now, we're starting the process. All I really want you to do is focus on your loved one and really enjoying that time with them. And I think that that's what's so stressful for so many families, is that they don't know, like, what do I expect as they come on hospice? What does the decline look like? So we really try to paint that picture for them so that they know. I mean, we don't have a crystal ball, but we really can guide them through that process from the very beginning. And it's always a same day admission. There is definitely a sense of urgency for us. And so typically within a couple of hours, once we have everything and we're scheduling, unless the family said, you know what, today is not a good day, can we schedule it for the morning? Now, there's situations where they're coming out of the hospital and they're declining pretty quickly. And so then we will make sure that we adjust based on where the patient is clinically. But the goal is within a few hours, and always same day admission, always.
Wow, that's great. Yeah. And so does insurance cover hospice? What's the cost of hospice? Could you speak a little bit to that now that we know how to get the referral, how to get started?
Sure.
But so who pays for hospice?
Well, this is the great thing, is that most of our patients are Medicare patients, right? 65 to 67. I mean, now obviously the age requirement has gone up, as we all know. But typically, that Medicare Part A is what pays for everything I mentioned. And I'll go through this again because I feel that it's a service that's still underutilized. I mean, when you have literally all of our team, the home health aide, we even have LVNs as well, the RN, the doctor, the home health aide, as I mentioned before, the social worker, spiritual, and the bereavement, and the chaplain. All these services are coming to your home, on top of being able to have durable medical equipment that's delivered to your home before the admission. So we're coordinating, as you mentioned, asking about same day admission. Many times, if from the time that we get that referral, we are coordinating the durable medical equipment to be in the home as soon as possible, so that we're not having to move the patient too much, right? And then getting them comfortable in a hospital bed and making sure that everything is set up before the admission nurse gets there. So all those components, and then the medications based on their diagnosis, we do medication review with them in the beginning, so that we're making sure that we're not taking away any of the medications that obviously are for their diagnosis, but it's under the hospice care plan. So we're all overseeing all those components, and that's all covered by Medicare Part A. And many of our families do have Medi-Cal or straight Medi-Cal. Now Medi-Cal has, you can choose whether it's Cal Optimum, Molina, there's some other different plans, and it's covered 100% with Medicare and Medi-Cal as well. So I think most people don't realize that. They're always thinking that there will be a cost when we sit down with them. We do what's called the explanation of benefits. And we all know what that EOB looks like. But I think, oh my gosh, well, I'm getting a bill. Nope, you'll get what's called an explanation of benefits, stating that you have elected the hospice benefit. And it's just letting you know that you've elected the benefit, because that's part of CMS. They have to let all their participants know. And so if they have private insurance, many hospices are contracted with multiple Blue Cross, Blue Shield, Aetna. And so we do all of that, calling the actual insurance company to get what's called their verification of benefits to make sure that they are covered. And most of the time they do have 100% coverage, unless they have a spouse that's still working and that's under their plan. There's other components to that, but most of the time I would say there is 100% coverage with hospice.
That's what's so great. And you mentioned something, Jackie, that I agree with, is that it's a very underutilized benefit. That there's a lot of individuals who would really benefit from that support that hospice provides. But, I think, like you said, is sometimes not knowing if it's covered, and then just having these misunderstandings prevents people from moving forward or exploring. Because some of the things that I hear the most from our end of the services that we provide are, concerns about, well, what if I've had my doctor for 25 years? Can I still have my doctor? And you kind of answered that, where the doctor's given that option. It's then up to them whether they proceed with that or not.
Right.
The other two things that I would say I get the most are, can somebody still see specialists, is one question. And the other thing that I would say is the most common that I get is concerns about treating or not treating things like a UTI or other type of infection, or some of those areas. And so I'm hoping you can speak to that too. Is I have a lot of families who are hesitant because they say, well, my husband gets recurrent UTIs, or my mom got pneumonia. What happens then? So would you speak to that for us?
Absolutely. So a UTI is one of the most uncomfortable things you can possibly, being young and having a UTI is painful. So imagine our patients that have dementia that can't tell you. They might be grimacing and, fidgeting, but you typically know by the smell, and it's an immediate. We don't want them to be uncomfortable. We treat UTIs, we treat infections. And I just spoke to a family about this, and I said, the whole goal of hospice is really for your loved one to get the care that they need wherever they call home, whether it's truly their home, at their house, or an assisted living, skilled nursing. And having an infection is not being comfortable. We treat that. As a matter of fact, we have a mobile lab. There's times that we send out a mobile lab just to, because there's something going on. And so we're doing, whether it's the albumin or checking for other infections and seeing what's going on with the resident, because that was what we promised the family, is we don't want you going in and out of the hospital. Let us bring all these clinical aspects to your home. So yes, we treat UTIs and other infections. And I think that is a huge misconception. I hear that a lot. We don't want your loved one suffering. We want them to be comfortable and clean. And I think that's a big piece of making sure that that's part of the hospice philosophy, is making sure that they are comfortable. The other one that you asked about is about the specialist. I will address that. So there are what's called billing modifiers, and many times when we meet with the family, we obviously encourage for them to keep their attending. A lot of times I will make the phone call with the family and actually call their attending physician just to see if the physician will follow while they're on hospice. And that way the family can hear, you know what, yes, we'll follow, and that, or no, we just can't follow. I can't make home visits. And that's okay. But let's say they do have a dementia diagnosis and they want to go to their neurologist. That's really because of many times they're going, it just depends on the reason why they're going. Maybe it's just a follow up, right? Because there's some medications that would be covered if that's their diagnosis under the hospice benefit. But sometimes families want to continue to go based on, let's say, whether they think that they can, their loved one can get better. And again, I think these are conversations with the family just to set the goals of care from the very beginning. And that's why we do that within the first 7 days of the admission, is do that care conference. That truly will understand where the family is. If they're seeking for aggressive treatment, then maybe hospice is not the right thing for them at this time. And that's okay. And what I also tell them, if you want to come off of hospice to get treatment, you absolutely can do that. It's your benefit. And then you can come back on when you're ready. We've had many families that have done that. And for certain diagnoses, they feel, okay, we've exhausted all the treatment. Let's say it's a cancer diagnosis where she's tired or he's tired. We don't want to do this anymore. So they've opted to, let's say, come off of hospice because they wanted to get that treatment, and then at that point made the decision as a family that they are done. So I feel that there's opportunities, I think, for more education. Yes, they can see their primary. With the specialist, it just depends on the goals, right? They can see them as long as the specialist understands that they are admitted to hospice and that their visit has to be basically billed differently, just because they wouldn't bill the same way they would normally bill if the patient was not on hospice. And they're basically called billing modifiers, and most offices understand that. But again, if they're seeing a specialist that has nothing to do with their diagnosis, they're fine. So hopefully
That's
helps.
really helpful. Oh, absolutely. I feel like I'm learning a lot today, which is great. It helps me when I'm talking to caregivers and others in the community. So I appreciate this.
Yeah.
Another thing that I get questions a lot is if there's an emergency, it's 2 a.m., something's going on with my loved one, what should I be doing? And let's say, I'll let you take it. I'll let you go first.
Sure. So we have from 8 a.m. to 5 p.m. You'll get our team, and that same phone number is on our binders everywhere in the home, and we're always making sure that the families know where to call. But that one number, as soon as 5 p.m. clicks, it goes into our after hours team. It's actually a live person that's picking up the phone. She's a nurse, Brandy, so everyone knows her. And so from 5 p.m. to 8 a.m. now we have actual Brandy's just triaging, and typically we are not, I mean, there's things that we can triage over the phone, but my goal and my protocol is that we're always sending out a nurse. And especially for falls, especially for, any type of, decline, it's important, especially when families are high anxiety, right? So we're always sending someone out. And I will tell you, it's definitely not 8 to 5. It's always after 5 and between 8 in the morning. So if it's 2 a.m., we will send out one of the runners, which is either Jenny or Gerson. And they start their shift from 5 p.m. to 8 in the morning.
Wow.
So, yeah.
Very helpful to know that. And I'm also just kind of wondering if you could, as difficult as it might be to figure out how to put all these together, but could you kind of describe the main difference between regular health care, palliative care, and hospice care?
Okay.
Best of luck.
I know. This one's okay. All right. So regular health care. And I feel for families sometimes because they are so. I just did a presentation on how to navigate the healthcare system in Southern California, which is really tough, right? So you have, let's just talk about, even if it's, an HMO or regular healthcare. Even myself, I have Aetna. So I just want a physical, right? I'm going to them, and sometimes it's very black and white. So I'm only going in for, let's say, internal med. I'm saying here are some of my challenges, but all the other specialists, now he's got to make a referral for me to see the specialist. And now I have literally, I have this app that now I have 4 follow-up appointments just from that one visit. And it might be 6 months from now because they're all booked up now. And, everyone's on trying to fit in all their healthcare needs before the end of the year. So I would say regular healthcare, you're going to them. Yes, they're providing those services, but you're still having to get blood work and all these other components that I think are important, because I feel sometimes we're not always proactive, we're more reactive, right, in healthcare. And so then when I speak about palliative care, and we'll jump to that, palliative care, again, it's having some type of life limiting illness. The most common diagnoses with palliative care is definitely cancer. And the reason being is because they can truly get what we call relief from pain while they're getting aggressive treatment. Typically with palliative, the word palliative means comfort, right? So it's providing relief. Palliative care is covered with Part B of Medicare if the hospice agency is certified with Part B. And it's typically driven more by a nurse practitioner and a physician. The difference with palliative care, though, is that the patient still has to order their own durable medical equipment, supplies that they may need, and those they still have to go back into the regular healthcare system for them to be able to provide that, because the palliative agency is providing basically, support and relief from the treatment. It's not quite hospice yet, right? And so then we'll go into hospice, where hospice is more comfort care without the curative intent. At that point, the patient may not have any more curative options, and they've chosen not to do any treatment. Where palliative care is comfort care with or without curative intent. And sometimes we see patients that they are hospice eligible, they meet the criteria, but they're not ready. And when I say ready, I mean they're not mentally ready for the H word. And so you see a lot of patients that stay on palliative care because they still can. Part B will cover the palliative care. And again, it's not a scheduled, it is a scheduled visit, but it's not as frequent as you see with hospice, because with hospice now you have the full team. With palliative care, you typically have the nurse practitioner. Sometimes some programs do also have a social worker, which is really important with palliative care, but it just depends on the program. I'm finding that standalone programs all offer different things. Some do have maybe a home health aide, but it might be the home health aide visit might be once every 2 weeks versus 2 to 3 times in a week, right? So very different goals of care. And I would say that with palliative care, it's a mixture of still being, what I say, dabbling in healthcare, which regular healthcare, because you still need to go in for treatment. You're still seeing your physicians, you're still seeing your specialists, but then the palliative team does come to your home. It's just not as routine as hospice care. So hopefully that, I know it sounds confusing. I'm confused actually, but hopefully that
I was
hopefully
going to
that
say,
answers the question.
I feel like that was a great explanation, and I appreciate how you kind
Yeah.
of connected them of, if these are the things that you're seeking, this is what happens, and then as you move through, and to share, I actually think that was very, very helpful and very clear. So thank you, Jackie. I know that was a
Good.
big ask. So
It's
I
a big one
appreciate it.
because I remember when I had launched in the past a palliative program, and the way that we always said it is that, with palliative, we basically have both hands. So you have the palliative care in one hand, and you're still holding on to that palliative care. And then, honestly, when you're ready for hospice, you can let go of palliative, and it's hard. It's really hard because, like I mentioned before, cancer is definitely the most the diagnosis that we've seen the most with palliative, because we never want to have families give up on hope. That's important. At the end of the day, that's their choice. We want them to be comfortable in the choices that they have made in their care. So,
Thank you for that, Jackie. And my
welcome.
final question, uh, what would you say is one of the most important things that you'd like to share with families who are watching this, or somebody who's considering hospice for themselves? What would you say is the most important thing that you'd want to share with those who are interested in hospice?
I would say that I want families to really know that they are the center of the hospice program. We couldn't do it if it wasn't for the families and the patients. But truly, the goal is for them to be part of the care plan, to initiate the care plan, and really to enjoy their family member, however long that is. And I think that for me, that's the most important component, because I've had some great experiences over the last few weeks, and being able to be at bedside with an actual patient that took their last breath, and not be and the family just being just grateful that they had that support system around them. Is it easy? It's definitely not easy, but it allowed the family member to be able to be there and be present while all the other pieces are being taken care of for them. So I would say that would be my probably the biggest thing that I would want families to know, is that it truly is a service for them and their families.
It's beautiful. It sounds like it's very sacred space that's shared.
It is.
Well, thank you, Jackie, so very much for joining us again this afternoon, for sharing such important information about hospice. Like we talked about in the beginning, there's just so many myths, so many misunderstandings about hospice. So I'm really glad that you joined us today to clear up some of those things. And I hope for any patients or families who might come across this video, I hope that this is useful information, and maybe relieve some of your fears, or maybe prompt you to reach out, ask some more questions. And we will do this again next month. We'll have another live stream event next month. It'll be on August 26th. Our topic is what is dementia, from 3 to 3:30 p.m. And with that, just thank you everyone for joining us today. And thank you again, Jackie, for being here with us.
Thank you for having me, Rachel. Have a great day.
You too. Take care.
Bye bye.